So the most obvious finding, this lady has a bilateral comptosis with superior and inferior sclerotial. There's an obvious thyroid stent, total sign. There's a reduced blinking also. The conch is injected. The caruncle is not injected. There's a bilateral upper lid swelling. Okay, look from the side. Okay, okay. So the Hirschberg is left eye is axial proptosis, right eye is non-axial proptosis. Then look from the side. First always have to wash your hand, then inform the patient when you understand. So I'm already washed my hand. So madam, I'm going to touch the neck. Okay. So if any pain, just let me know. Just relax your neck. Okay. So first you have to look up. Then look at the apex of the cornea for both eyes, and then you compare with the orbital rim whether there's any protrusion.
You need to lift up the eye finger.
Okay, then when you are at the back already, you just palpate. Palpate any cervical lymph adenopathy, preauricular lymph adenopathy. Okay, and then you check the back. Okay, ask the patient to swallow. Ma'am, can you swallow? Okay, so there's a palpable thyroid mass that's moved with deglutition. Okay, then after that, proceed with EOM, right?
Only PD you have to check. Belum check. Dia belum ambil touch.
Okay, I just check Hirschberg.
Yeah, Hirschberg yang ada di history. Then you ask someone to read the line for you.
Don't swing, ah.
Yeah, exam don't swing.
Direct. 1 2 1 2 1 2 1 2. IPG.
Okay, so ma'am, we just look at this pin. Okay. Do you see two?
No.
Okay. Just you are here. If you see two, let me know. Okay. See one or two?
1.
Do not cross your hand. See one or two?
1.
Okay, just look up. Okay. So when I'm asking the patient to look up, I'm also checking for sensitivity test. About 10 to 15% of the thyroid patient have MG. Okay. So this patient doesn't have a sensitivity test.
Look at the watch.
Ideally, I want to check for 1 minute due to exam time constraint. I'll proceed. Okay, there's no obvious defective PP. Then ask the patient to look down. Okay. When the patient look down, there's a lid lag. Okay. So, okay, I'm checking for Kogan lid twitch. Ask the patient to look down for 30 seconds. Okay, due to exam time constraint, I'll proceed. Okay, ma'am, when you later I ask you to look straight, you just immediately look straight. Can you look at my finger? Okay, there's no Kogan lid twitch. So, UM examination, the UM is full, there's no fatiguity test. Fatiguity is negative, there's no Kogan lid twitch. Okay. Then after that, you go. Okay, because I asked the patient just now to look down, my method is when the patient look down, just straight away ask the patient to close the eyes. Okay, so when closing the eyes, actually you can check 3 things. So you can check any palpable thrills. Okay, just close the eyes. Okay, there's no palpable thrill. Okay, just check for retropulsion. So you have to push the globe, and then you release feel for the retropulsion. So this patient has none. Then last, you have to use the dial of the stethoscope to check for the audible bruit. So 3 things. I'll pay for thrill, for the retropulsion, and then bruit.
So after that, you close your eye, your eyelash sign and eye peak sign for admission.
Yes.
See the lashes whether can bury or not. When there is fatiguity, the eyelashes is not very nicely seen. And when it's eye peak sign, when you close your eye, the eye will slowly drift open because of fatiguity cannot remain closed. That one dosis. This one is MG.
Okay. So this is proptosis. So I'll still do all the examination for thyroid eye disease. Okay. Then after that is finished already. Then we go to the hand. So actually hand, the back of the hand and then this part of the hand also got finding. So this part of the hand you check, see grossly any fine tremors, look for any nicotine staining, and check for thyroid acropathy. Then can you do this? Okay, look for clubbing. There's no clubbing, no obvious thyroid acropathy. And then you turn over the palms like this. Then you check for any palmar erythema. And then you just gently swipe, see hands whether sweaty or not, see if there's increased temperature, whether there's a warm. Okay, and then you just check for any radial below. Okay.
AF, absent PV, and tachycardia.
Then after that, you just want to check for collapsing power, right? So, ma'am, I'll hold your hand and wrist. If any pain at your shoulder or wrist joint, just let me know. Okay, so you want to feel for the radial pulse at your palm. Okay, and then you have to suddenly.
Yeah, but this one you also have to
So
look
there's
at
presence
the
of
brachial
collapsing
pulse. If not, you are not. Yeah, detecting.
Okay, there's no collapsing pulse.
Okay.
Okay, so then the last one, the fine tremor.
Stretch out straight the hand.
Stretch out straight.
Then you put
Then ask the
the
patient to
paper.
close the eyes. Okay. Okay, that's better than fine tremor. Okay.
The leg now.
Then last is the proximal myopathy. So you ask the patient to go up like this. Press.
Okay.
So no. And then you other thyroid is pretibial mixed edema. Okay, so this patient have no obvious pretibial mixed edema. There's no lower limb wasting. Okay. And anything else?
Any swelling over the ankle. Press on the ankle. See whether there's any pricking or not. They can have CCI. If let's say there's cardiac failure, that one you want to complete examination. So leg pretibial mixed edema. Press on the ankle to look for pitting. Then another one, if you want to try on the proximal myopathy, ask the patient to get on the leg, then you tekan. See whether kena or not. But usually no need. This hand settle then hit can already. So then finish it.
Let's say this is a TD patient. They'll ask you to proceed.
You still have to
Examine
do the
the
examination. They want to.
Don't lah. I'm very camera shy. Okay. So the
You must see you lah. But they don't show you lah. They even one lah.